Hello, everyone. I'm Dr. Galen Henderson, neurologist at the Brigham and Women's Hospital, and I'm here to talk to you today regarding clinical pearls and give you take-home messages. For this course, I chose this subject, the examination of the comatose patient, because I wanted you all as providers to get a more rounded experience dealing with the neurology patients. So for this section for neurology, you will cover things such as headache, stroke, epilepsy, but I also want you to feel more comfortable with examination of the comatose patient. I have no disclosures to acknowledge. Here are the objectives over the next 30 minutes or so. So at the end of this, hopefully you'll be able to better perform the neurological exam in a comatose patient and assess airway and the need for ventilation when that's necessary or not, how to establish the diagnosis for a cause of a comatose patient, and determine what the most likely cause is and things that we should consider for that patient population. As we begin, I want people to be aware of what a coma actually is. Remember that a coma is a pathological state, which looks very much like sleep, and sleep is a form of coma, but it is not a pathological state. So there are two components with this pathological state. You must have arousal, meaning wakefulness and eye opening. And the second part is awareness. So if we start from the levels of awareness or existence from the bottom, there is brain death, meaning legally consistent with that of cardiac death. There is no response. There is nothing at all. No brainstem reflexes, absolutely nothing. That patient is clinically dead. Above brain death, there is the comatose state, and which the patient does not have any arousal or awareness. The next step up is a vegetative state, meaning that the patient may have some signs of wakefulness, meaning that they possibly can open their eyes, but they're not following any commands, they are not processing, and therefore they're vegetative, not comatose. And then some people have used the term minimally conscious state. This is a term that we don't use as much in the intensive care unit, and because it's hard to determine where the ceiling is for this definition. It usually means a person with severe psychomotor retardation, and they will respond, but the response is very, very delayed. But a comatose state is no arousal and no awareness of the environment. When patients are being evaluated in the field, emergency medical services are typically looking at the airway, breathing, and ventilation. They perform their rudimentary scales, making sure that they have intravenous or interosseous access, and ruling out some of the basic things such as hypoglycemia. It is incredibly important that we understand what's happening in the environment, what type of environment that the patient was found. Is it in an abandoned building, or is it in an office? Were there pills around? Were there needles around? All of this in the environment or people, this is important. And also the timing of this unresponsive state for those people who may have been bystanders or witnesses. Was it a sudden loss of consciousness, or was it something that progressed over minutes, hours, or several days? When were they last seen normal? All of these things are very helpful in determining what's going on. And remember, with all of this, with the neurological exam, it's all about location, location, location. So it's all about localization. And we'll show you how to localize where the lesion is before we determine what that lesion actually is. So for the approach to comatose patient, level of responsiveness. Back in the old days, people used to use the term obtunded, lethargic. Well, we really don't say those things anymore because I think those words are used interchangeably. It's important to know what the patient is doing when you assess the patient and what stimulus does it take to get a response. So is it voice that causes the patient to arouse, or is it noxious stimulation that causes the patient to arouse? Is it sternal rub, or is it nail bed pressure in the four extremities that causes the patient to arouse? That's a better way of determining the level of responsiveness other than using the terms lethargic, obtunded, and things like that. We will review issues of the brainstem examination. We'll go through those in detail. And we'll look at the motor examination and tone and see if there's any asymmetry, because asymmetry does help with localization. If they're moving one side of the body more than the other, that's important to know about. And we also pay attention to breathing. Breathing is also very helpful with localization of the neurological injury. So in determining level of responsiveness, many early on in the field or in the emergency department will perform simple things such as the Glasgow Coma scores. And remember with this score that any number totaling less than 9 is considered comatose. And that's important to remember. Very effective if you're communicating this patient has a GCS of 7 versus an 11, that's a tremendously big difference. With the brainstem assessment, so we've assessed with the comatose state if the hemispheres are intact and if the patient is not awake and does not arouse to stimulus in all four extremities. We then start to assess the brainstem. So we hold the patient's eyes open to see if there's any visual threat to response. This does help with localization of looking at cranial nerves 2 and 7, that reflex arc, because people with things intact, they will have a normal bilateral blink response. So it's important to open their eyes. And if I were to test on myself, come at the patient kind of like that, as if you're going to hit them in the eyes, we would expect to see a blink. If there's no blink, there's no blink to threat. Then we go further with the pupillar response, and this is incredibly important. And on the following slide, I have much more detail about this. But overall, if they're pinpoint, this does raise concern for pontine damage or toxins. And if they're very large and unreactive, we're concerned about midbrain lesions, or if this patient is herniating. For eye movements, if the patient is spontaneously able to move the eyes, look right, left, up, and down, fantastic. But for those patients that are unresponsive and cannot move their eyes, we will try the Dahl's eye reflex or the oculocephalic reflex. And remember, with this reflex, you cannot do it if a person has a cervical collar. And so if your patient is found in the unresponsive state, they will have a cervical collar and you will not be able to perform the Dahl's eye reflex. But for those where you can perform the procedure, the normal response is if the patient is, you open the eyes and the eyes are straight ahead, you turn the head quickly, and then the eyes will move towards the head like this. Now that is a normal reflex. If the eyes are moving with the head, like a doll, with the eyes pinned on, like in the 1930s, that is a bad sign. That is that lets us know that that part of the brainstem has been very, very damaged. That's with the oculocephalic reflex. Like I said, for those patients with cervical collars, you can't do that, and you can perform the cold caloric test. And the example that I usually give is if you inject cold water into this ear, the eyes should slowly go towards the water and then snap back. So the mnemonic that many may have learned, cows, cold opposite warm the same, that is for the fast phase of the nystagmus. And we look into the ears, we make sure the head of the bed is up 30 degrees. We look into the ears, make sure there's not a lot of wax and that the tympanic membrane is intact. We inject 30 to 50 cc's of cold water, and we hold both eyes open, see if the eyes moves towards the cold water and snap back. This gives us information regarding the integration of cranial nerves 3, 8, and the cerebral cortex. Incredibly important. If we don't see any movement, we know that there has been severe damage along the pathway, or if we just see one eye move over or the contralateral eye move over, we know that there has been significant brainstem damage that we should be aware of. And we test each ear independently. Next, we will look at the cranial reflex. With the cranial reflex, remember this is cranial nerve 5, which is the sensory aspect, the afferent part, and cranial nerve 7, which is the which closes the eye, which is the blink reflex, and that should be bilateral. And then we move further down the brainstem with the Yankauer suctioning catheter to see if there's a cough or a gag reflex. And that is the brainstem reflex, the brainstem examination. In more detail regarding the pupils, this is what I meant earlier. So for those pupils that are pinpoint, we get concerned about opioids, so cholinergic issues or pontine damage. If they're dilated, here are some of the toxins that the patient may have been exposed to or other pathologies that may have occurred. So of the brainstem exam, the pupils and eye movements are probably the most important part of the exam. Motor function, I think the biggest issue is if there's a normal spontaneous movement. If there is not, is there decorticate posturing, meaning the arms are coming up as you're stimulating the patient, or the tonic extensor posturing, the decerebrate posturing. You know, often people try to discuss which posturing is worse, decorticate or decerebrate. Trust me, both are bad. So it's not that important if it's decorticate or decerebrate. Both are bad. And it's important to note what that exam is showing. Muscle tone is important, and of course, reflexes, knowing whether the toes are going up is important, or if there are no reflexes at all, incredibly helpful. And if there is some movement, we have to determine if their motor exam is purposeful or if it just is a reflex activity. Sometimes it can be difficult to determine the difference between the two. And breathing patterns can also help localize. If you were to look in many neurological ICUs, you'll see that most patients are slightly alkalotic because many of them will have neurogenic hyperventilation. It can localize to the midbrain and pons, but it's something that we see in many of our patient populations. If you were to see clustered breathing or ataxic breathing, it is much more concerning, but also very helpful in localization of where the problem actually is. Of the respiratory patterns that you see on the left side, Cheyne-Stokes is probably the one that is seen the most and also is the most non-specific. And usually when I see this in patients, I think of more metabolic issues or issues of things like congestive heart failure. This is probably one of the more common types of breathing disorders seen in the medical ICUs or patients with CHF. And even though the patient breathes greatly and rapidly for a few seconds, it's followed by a period of even apnea. And for those patients that are ventilated, the apnea alarm may sound off, but the patient never desaturates. And so you shouldn't really be worried about this. But I think in the beginning, when you're first assessing the patient, this is something that is important to note. And of course, central neurogenic hyperventilation is something that we do see many of our patients. Apneustic and cluster breathing, if we start to see that, we really are trying to protect this patient's airway because they're probably snoring and it's obvious that they're having some difficulty. Even though they may not have desaturated, they can still run into a lot of problems very quickly. And also we expect these patients to have a higher incidence of having aspiration pneumonias. For the approach of any comatose patient, we want to make sure that we're giving them glucose after their glucose has been checked. And if we're going to give them thiamine, we want to give them 100 milligrams IV before we give them the dextrose. And I think with many patient populations, even in the field now, police and other first providers will give naloxone because of the concerns for overdose in this current time. At some point, we will consider performing a head CT to look for structural cause. And for those patients who may have vascular problems, we will perform a CT angiogram. And I'll say more about that in a few minutes. As I said, we want to know the historical account, what's happened, if they have any comorbid diseases, their medications, exposures. All this type of information is very helpful in drawing a picture about what's happening with this patient, and it helps us develop a much better plan. Time course is incredibly important, if it's abrupt or is it gradual, and all of these other factors as mentioned before. Let's start with a case. So here's a 60-year-old man. He's found unresponsive to voice, found in a hotel room by the housekeeper. This is a kind of a real life story. The last time he was seen well was the night before, and he was brought in by the emergency medical services of that city. When seen, he was slightly hypothermic with a temperature of 34 degrees Celsius, heart rate of 60 beats per minute, blood pressure 185 over 95, respirations of 10, satting at 92%, Glasgow Coma score was 4. So this patient is definitely comatose and hypo. The next question is for the provider. What is the next step? A, treat the elevated blood pressure with nicardipine drip. B, assess airway breathing and circulation. C, a stat head CT. D, apply warming blankets to treat the hypothermia that the patient is undergoing. The correct response is B, assess the airway breathing and circulation. This is incredibly important, and I think half the job is done when you assess these issues and stabilize these issues first, and deal with other things afterwards. With the neurological assessment, the patient has closed eyes with gaze that is disconjugate. So, okay, with the eyes that are disconjugate, we get concerned about something that is affecting the brainstem. Does this person have a lesion there that is causing this? Or does the patient have a baseline history of disconjugate gaze? We are to assume that they should have their eyes in the normal primary position. Oculocephalic reflex is intact. It's good to know that the pupils are symmetric, reactive, but they are a little bit enlarged. There's no response to pain. Motor tone is diminished and no deep tendon reflexes. Wife is contacted over the phone. The airway, breathing, and circulation is assessed. The patient was intubated due to the inability to control the airway. Also, there's unknown cervical spine stability and the possible elevated ICP, and labs were sent. From the wife, we were able to get the history of coronary artery disease, DVT, type 2 diabetes, and depression. And we see the list of medications in remarkable for the apixaban, metformin, amitriptyline, and other medications for depression. Because of the apixaban, we want the pharmacists in the emergency department to be aware of this, because we may need a reversal agent, and it does take some time for that to become prepared. Labs that are usually performed, here are the basic labs, and I should remember to tell you that in regards to your toxicology studies, it's important to remember what your toxicology screen at your institution provides. what's in that list of everything that it tests for and what's not in this list for what it's testing for. Incredibly important. Uh, Consider either you're going to be getting an arterial blood gas. Oximetry is also important. The blood gas is important to look for pH and also your PCO2 because many people can have normal saturations, but if they are not ventilating well, they can have very high PCO2s and have CO2 narcosis and even seizures as a result of their retained PCO2 from poor ventilation. Some of the causes of coma, we think about it as either bihemispheric damage or brainstem damage, because if we think about the reticular activating system, it's in the brainstem, or the inputs to the reticular activating system from below or from the hemispheres above. So if we were to look at focal lesions, you see them as far as trauma or stroke, but patients may have toxic metabolic causes, and you see a list of them here. On the left side of the screen could also be PRESS or hypoxic ischemic injury. PRESS is basically another form of hypertensive encephalopathy. And going back to our case, is it a structural insult? Is it a metabolic abnormality? We performed our examination, and there are remarkable things on this clinical exam. Other than the level of consciousness, the disconjugate gaze is something that is very concerning. Therefore, what is the next step? A, brain MRI. B, naloxone, 0.4 milligrams IV. C, hyperventilate the patient. D, head CT. The correct response is D, head CT. So if the cause is unclear or there is a focal exam finding, we do want stat imaging, and we have to use whatever is available to us. If one of the choices had been CT angiogram, I probably would have chosen that to make sure that there is no vascular lesion that's obvious as well. When CT angiograms of the brain are performed, we do brain and neck, and typically with the routine study, they start at the top of the aortic arch, and they go all the way to the top. So it's a nice poor man's conventional angiogram with this CT angiogram. And so this is what is seen with the image to the right. This is a large subarachnoid hemorrhage with intraventricular extension, as well as hydrocephalus and trapping of the lateral ventricle. So CT of the head shows intraventricular hemorrhage with hydrocephalus. Pharmacy is noted because of the possibility of using andexanet alpha to reverse the apixaban. And this is where timing is incredibly important. If it's been past a certain time period, it's believed that the effects of the apixaban would be out of their system and no need for this reversal agent. So the history really does make a difference. Neurosurgery is consulted for placement of a life-saving external ventricular drain and to treat the intracranial pressure that is presumed there. We will hyperventilate this patient until that is placed, and therefore mannitol is very helpful in this patient in trying to buy more time and treat intracranial pressure. But for many of those patients where the CAT scan is completely normal, we're waiting for the labs to come back. There's nothing on the labs. The CAT scan or CT angiogram also is completely normal. We will need additional evaluation. We would consider an MRI, but other things that to put higher on the list is if there's any sign of any fever or infection, to consider a lumbar puncture, and also continuous digital EEG monitoring. We do now know that many patients will have seizures, and sometimes be in subclinical status. And so this is something that's important not to miss, that we want to be on top of as well. So overall, wanted you to perform the neurological exam in the comatose patient, learn how to localize what's going on based on the exam, get a sense of what to do based on the history and the information that we've accumulated, remembering that airway, breathing, and circulation is one of the first things that should be assessed and evaluated. We just don't intubate. We only intubate when people are having problems maintaining their airway, and we want to establish the cause for the coma. Some of the pearls and take-home messages. Key findings on the neurologic examination of the comatose patient identified changes that's to suggest toxic metabolic syndromes that can lead to coma or structural lesions. For comatose patients, please don't forget that basal artery lesions can cause a comatose state, or even bilateral carotid occlusions can do the same thing. Some patients may need to be revascularized with their catheter-based procedures. Elevated intracranial pressure can be seen in a variety of processes, but cannot be excluded by imaging alone. So it really does make a tremendous difference on what's happening with the patient. And a lot of that is based on the history and the exam that you perform in the emergency department, or when this patient is being urgently seen. Thank you very much for your attention, and enjoy the rest of the course and this section on neurology. I'm Dr. Galen Henderson, Brigham and Women's Hospital, Department of Neurology.